Great. Hi, everybody. I'm Dr. Scott Irwin. I'm a psychiatrist by training, and I direct our Cedars-Sinai Cancer Patient Family Support Program for the Cedars-Sinai Cancer Enterprise. Let me share my slides. Can you see those? Yep. Okay.
Good.
Oh, you all moved over here. Let me put you back where I can see you. There we go. Great. So today we're going to talk about what depression is, how we can screen and assess for it, and some approaches to managing it. And we should have plenty of time for questions. So, what is depression? Maybe if some of you want to speak up or write something in the chat, what do you all think depression is?
Feeling sad and lonely.
Feeling sad and lonely?
Mhm.
What else?
Hopeless sometimes
Sometimes being hopeless,
and overwhelmed.
overwhelmed. Great.
Not having joy in anything.
Yeah, not having joy is a big one, especially
Yeah.
in the with patients with cancer. So the thing to remember is that depression can be just a normal symptom of life. We all get sad from time to time. That's completely normal. It becomes an episode when it meets certain criteria that we'll talk about, and then is considered in medical terms a disorder when you have multiple episodes. So depressed mood and decreased interest in or pleasure are the two sort of cardinal symptoms of depression, and you need one of those two. And the decreased interest or pleasure isn't that you can't do the things that you enjoy, it's that you wouldn't enjoy doing them if you could, or not getting joy out of things you would think you should. There'll be people that'll say, I love my family, but I'm just not getting any joy of spending time with them, which is, really abnormal and distressing. And that's depression. So hopeless, helpless, worthless, excessive guilt, indecision or poor concentration, sometimes suicidal ideation, can be weight changes up or down, sleep changes more or less, decreased energy, and changes. People are often slower in the way they move or talk. And technically, for a diagnosis, if you have 5 of 9 of these symptoms, including one of the first two, all day, every day, or all day, most of the day, for over 2 weeks, then it becomes what we think of as clinical depression. And for me, that's the line between do we need a medication or not. Sometimes people have some depression or trouble coping, and that might be more amenable to talk therapy. And sometimes it's just a normal, we have sad days, and that's okay. One of the things we need to do in the medical profession is also not intervene on normal things just because they might be uncomfortable for a little bit. So in medical illness like cancer, those things like energy, appetite, being slowed down are not often helpful, right? Because that goes along with having cancer. It goes along with side effects of cancer treatments. So we really focus on the dysphoria or sadness or despair, the anhedonia, which is another word for that not having interest or pleasure, the worthlessness, hopelessness, helplessness, guilt. Often there's a loss of self-esteem. Why can't I just do better? And then for some patients, a desire for hastened death. So depression is really common and disabling and economically costly. So 332 million people, about 4% of the global population experience depression. There's about 12 billion lost working days annually due to depression and anxiety combined, and over a $1 trillion annual productivity loss for depression and anxiety combined. It's among the leading causes of disability worldwide. We saw depression and anxiety raise 25% during the first pandemic year. And the functional impact is broad: fatigue, low motivation, impaired concentration, not showing up to work, showing up to work but not really being present, difficulty managing, life, everyday life things like paying bills, getting dinner on the table. And 1 in 6 adults will experience depression, and women will experience it more than men on average. In advanced cancer, up to 60% of patients have symptoms, right? And it's my job to figure out, is this a symptom of just, normal everyday coping? Is it symptoms that are not quite rising to the major depression, but need some intervention of some kind, usually not medication? And then up to 16% of patients will meet criteria for clinical major depression. And I use this number to say, this is why when people say, well, isn't it normal to be depressed when you have cancer? The answer is no. Yes, more than half have symptoms, but, less than 20% actually meet a clinical diagnosis for depression. So it's not normal. So it's not normal. We can treat it. It's also a reason not to just put people on antidepressants because they have cancer, because 80% of them won't get depression. So why give them a medication that they don't need? But I see both of those things happen fairly commonly. So it's often misdiagnosed or unrecognized. In a study of 200 patients with advanced cancer, oncologists identified only about half of the patients who they screened as depressed, that were depressed. And it's often missed, under, or untreated. So this was an analysis of 21,000 patients. 1,500 of them had depression, and 73% were not receiving effective treatment. And it goes back to, well, it's normal. They're depressed. They have cancer. Well, again, it's not normal, and we can do something about it. So what are the consequences? Untreated, it's actually associated with a poorer prognosis. People will not live as long and do as well if they're depressed. It can undermine self-esteem, worsen medical illness and quality of life, increase healthcare utilization and cost. So patients with depression and cancer often go to their oncologist on average 7 more times a year than patients without depression. And they're seeing their oncologist, who isn't necessarily an expert in depression. It can interfere with capacity to make decisions, understand the situation and options, interact with their caregivers and loved ones, and ability to reach final goals if people are heading down that path. So what can we do? Well, we can screen for depression, and it's really just 2 questions, and it's those 2, symptoms that I said one of them had to be a part of this. So it's, over the past 2 weeks, how often have you been bothered by the following problems? Little interest or pleasure in doing things, feeling down, depressed, or hopeless. And this is scored by, several days as a 1, more than half the days as 2, nearly every day is 3. And this is a very good screen for a score that's 4 or more. So a score that's greater than 3, that people will have clinical depression. Now, it is a screen. Screens are not perfect. And we also talked about how patients with cancer can the criteria don't exactly fit. So this doesn't mean, yes, they have depression. It means there's a high likelihood and somebody should do further assessment. But if you're worried that one of your friends, colleagues, loved ones, patients has depression, this is a good place to start. So when I'm doing an assessment, I want to interview the patient. I also want to hear from family, because quite often they notice things more than the patient does. Patient will tell me, oh yeah, they're doing their normal things, and the husband will say, well, you haven't wanted to go to the movies in 4 weeks, and that's not like you. We used to go to a movie every week. Oh, I guess you're right. On the flip side, when I start treatment, often, because of the way the medications work, the patient's the last to know it's working, because the feeling of depression is the last thing to lift, but energy and doing things and joy comes back sooner. And so family members will notice that it's working before the patient will. Review of any risk factors for depression, which we'll discuss. A good medical exam, and we'll talk about, there are medical causes and medicines that cause depression. So if you have a low thyroid, the answer is not give you an antidepressant. The answer is fix your thyroid, right? So we have to be mindful that not all depression is psychological or emanating from our brain. And then what are the desired outcomes of the patients? Patients may refuse to take medications. Patients may not be interested in talk therapy. Patients may be okay being depressed. And as long as they're safe, we have to allow them to have that choice, even though we know they would make different choices likely if they were not depressed. And then what's the context of the symptoms? Again, in medical illness, are we talking about somebody just diagnosed with cancer, somebody that's cured, somebody that's in remission, or somebody that's at advanced cancer? So the risk factors, so in general, for everybody, having a prior history of depression, a family history, especially in first-degree blood relatives, increased social economic stress, any previous suicide attempts, and substance abuse are all risk factors for depression. In medical illness, poorly controlled pain. In fact, I just saw a patient yesterday. She had to have surgery, and she was in excruciating pain after the surgery, and her depression was horrible. But by the time I saw her yesterday, the pain had subsided and her depression was better. So in that case, it was control the pain, not increase her antidepressants. Getting progressively more physically impaired, having advanced disease, and then, like I said, certain medications can cause depression, like steroids, which a lot of patients take, chemotherapies, some of the immunotherapies, some of the hormone modulators like tamoxifen, and then benzodiazepines, which we use a lot for anxiety and sleep, are actually depressants and can cause depression. It's associated with particular diseases, although there doesn't seem to be a cause and effect, but particularly pancreatic, breast, and lung cancers, and also any disease that's gone to the nervous system. Younger age. Why do people think that younger age would be more associated with depression? Any thoughts? Speak up or in the chat.
Could it be just the environment that younger people are surrounded by, like social media and having just that input constantly, like just scrolling and things like that?
Yeah, I think that's true in the general population. I should have been more clear. I was talking about in patients with cancer. And somebody put in the chat a more significant change in life. So I think you have that general overlay of just today's generations for the general population. And then in cancer, it's the sort of more loss of potential and more loss of future. As adults, we kind of know what we're going to miss out on, or we've done a lot of the things that we want to do, even though we may want to do many more. Whereas kids are losing a lot more of that potential. And then somebody also said in the chat, which is true, younger people have less means to deal with difficulties. I think that's changing now. It's certainly less stigmatized, and those generations talk about mental health a lot more than we did in my generation and before. But still, and then we just have a lack of resources in general, although we've gotten better since the pandemic. Yeah, loss of career travel opportunities, just that loss of perceived future. That impacts all of us, no matter who we are, when we're on a path to the future and we get knocked off that path by something like cancer. But for younger people, there's more of that path in front of them. And then spiritual pain, also a cause of depression. And sometimes it's spiritual pain like, why is God doing this to me? What did I do? Or sometimes it's this is God's will and this is what God has in store for me, but it still causes some spiritual pain. And those are two ends of a spectrum. People are somewhere in between usually. So for medical assessment, what I want to do is I want to review all medications and their history and how they evolved as far as dosing. Because like I said, medications can be a cause of depression. A good history in physical, knowing people's allergies, any alcohol which is a depressant, benzodiazepines, which are actually powdered alcohol that are depressants. How are they thinking? And then some good blood workup too for all these things that could potentially contribute to depression. And vitamin levels too are important. Lack of some vitamins can lead to depressive symptoms. I want to just shift gears and talk about depression versus grief for a minute. And grief is really our reaction to any loss. You know, we often think of it for a death, but you know, you could a kid could lose their favorite toy and grieve over that. You know, we could lose our favorite car and grieve over that. And often in patients with cancer, I see exactly what we were just talking about, a grief around losing the path of life that they were on, or the potential that they had, or what they had expected for their future. So I often see a lot of grief within the patients, and I need to differentiate, okay, is this normal grief and maybe they need some support with talk therapy or other things, or is this really a clinical depression where I might think of medications? And so in grief, there's usually an identifiable loss, like I just mentioned, whereas in depression, the loss may or may not be identifiable. In grief, the focus is on the loss, and in depression, the focus is on the self, that I feel so bad. Both have sadness and emptiness. In grief, the emotions come in waves, where in depression, they're chronic. And I often describe as grief gets better. It's kind of like, you know, we're fortunate living in California. Not everyone can visualize the ocean and the waves, but, you know, I talk about grief coming in waves, and over time, the waves become shorter and they become further apart. And that's how I know that grief is progressing normally as far as people coming out of it. In grief, there's this fluctuating ability to feel pleasure. Some days you will, some days you won't. And in depression, there's really usually an inability to feel pleasure. Grief, we like to surround ourselves with people or to talk about the loss with them, whereas in depression, people isolate, which is kind of perpetuates the depression. Self-esteem in grief is stable, whereas there's this loss of self-esteem or feeling of worthlessness in depression. There might be some specific guilt or regret. You know, I really could have done a better job, or I could have been more there for the person, or I could have, you know, paid more attention to where I put my toy and didn't lose it. Whereas the guilt in depression is out of proportion, like a lot of self-blaming and this is all my fault kind of thing. If the grief has to do with a loss of somebody, which we actually call bereavement, there might be thoughts of wanting to be with the deceased. But in depression, you can see thoughts of active wanting to harm oneself. And then in grief, when it includes with the bereavement, when it includes the loss of somebody else, you can have non-bizarre hallucinations that are normal. So thinking you hear the loved one, thinking you see the loved one are all fairly normal reactions. Whereas if you have depression with what we call psychotic features, there are bizarre hallucinations of seeing things that are really not there and are kind of bizarre, or delusions of bugs crawling on you, or the TV talking to you, or just sort of weird things that can happen if depression becomes severe and starts to have those symptoms. So let me stop there for a second. Are there any questions at this point?
I can't tell. Can you hear me?
Yes.
You mentioned tamoxifen, and I was very surprised to hear that. I'm on it. Can you say anything more about it?
So some women on tamoxifen do really well. Some struggle with sort of menopausal symptoms because that's taking away your estrogen. And then there are women that get pretty severely depressed from it. All medications have side effects, and you may or may not get them. All medications don't work 100%. So any medication may work for you, may not, may work with side effects or without. It's really all trial and error. So for all the medications I use, just because one antidepressant has side effects doesn't mean another one will. Just because one works doesn't mean another one will. So I would say if you're on tamoxifen and you're not struggling with these things, you're probably good because those come on pretty quickly. It's rare
Okay.
for side effects to come on after you've been on a medication for a while, unless you bump the dose, in which case,
Thank you.
anytime you change the dose, it could change.
Okay.
So how can you find a reputable psychiatrist for help with this? There are psychiatrists out there that are in private practice that consider themselves psycho-oncologists, or most of the major cancer centers in town have psychiatrists. So City of Hope, USC, Cedars, UCLA, St. John's, all have psychiatrists. I would talk to your oncologist or your primary care doctor to help you if you need that, is where I would start. Okay, so how do we treat depression? And we'll have time for more questions. So again, we want to review what the patient wants and what their desired outcomes are. We try to relieve suffering, and we can do that non-pharmacologically and pharmacologically. And in depression, head-to-head talk therapy and antidepressants do about the same, but together they're synergistic. And so if I'm going to give a medicine to someone, I always recommend talk therapy. If you're back to the head-to-head, talk therapy versus medicine, talk therapy sort of takes longer to take effect, but also lasts longer once you stop, whereas the medications work a little faster, but once you stop them, depression could come back faster if it's going to come back. So the takeaway is always psychotherapy or talk therapy or some of the other things I'll talk about that are non-medicine, and then medicine if needed. And then, as you just asked, how do we get a psychiatrist or a mental health professional to assist? So in psychotherapy, there's cognitive behavioral therapy, which is, the famous psychotherapy because it's the one that's been studied the most. And there's group therapies for cancer patients with cancer that reduce stress and mood symptoms. There's existential group therapies that were developed for patients with cancer that focused on value and meaning. And my colleague out of Canada developed dignity therapy, which reduces depressive symptoms and a sense of suffering as well. And I am concerned less with what kind of talk therapy as much and more about the rapport and the feeling of support for patients in talk therapy. And I often caution patients when they're getting a therapist that, yes, sometimes therapists are not a good fit. I may not be a good fit for somebody. That's okay. We can find another psychiatrist. A therapist may not be a good fit. That's okay. We can find another therapist. But in therapy, things often get a little worse before they get better because you're starting to really focus on these things. And so you have to be careful that you don't run away because things are not feeling good. That if you're going to leave, it's really because it's not a good fit and not because things are getting uncomfortable. And it's by working through that uncomfortable period where things get better, if that makes sense. There's other complementary therapies, guided imagery, muscle relaxation. We talked about this in the anxiety talk a week or two ago. Meditation, massage, aromatherapy, avoiding caffeine and alcohol. As I mentioned before, treating insomnia makes almost everything better. Not cure it, but makes it better. Exercise too, and then any bright light exposure that we can get, especially with depression. In Southern California, we talked about this with anxiety for those that were there. If you can get 30 minutes of sun with no sunglasses and no sunscreen, moderate for your skin type. We don't want any burns or, increased risk of cancer, but it's that getting that vitamin D and getting the light into your eyes that really helps. 30 minutes a day if you can do it. So I see some questions coming up. I'll wait till the end and answer. So as I mentioned, for moderate to severe depression, psychotherapy plus antidepressants, you want to increase the dose over weeks. They can take 4 to 6 weeks to work. And if there's no improvement by 6 to 8 weeks, you want to adjust the treatment and monitor for another 6 to 8 weeks. So it takes a while. And then after remission, you want to continue for 16 to 20 weeks and then maintenance for a year or two. And the reason for the year or two is the same reason we put people on tamoxifen, because it lowers the risk of recurrence after you stop the medication. If you stop the medication before a year or two, your risk for depression coming back is a lot higher. Partial response is associated with poor outcomes. So you really want to get people to have their symptoms go away. So in the real world, this was a NIH, National Institute of Mental Health treatment study of 4,000 depressed patients at 41 clinical sites around the country. People got 14 weeks of therapy with Lexapro, which is escitalopram. Only 50% had a response and 30% reached remission, right? So 70% failed with initial antidepressant treatment. If you add or switch the medications or add CBT, you can get another quarter to a third to improve and a 50% overall remission. And if you continue and maybe try a third medication, you can get up to a 70% remission. So this is all to say that it can take time, and it may require several levels of intervention to get people to remission. On the other hand, and so, well, I'll get back to a way we can get around that a little bit. So we have all of these different classes of antidepressants, the SSRIs, the SNRIs, or SNRIs are like Cymbalta and Effexor, SSRIs are Prozac, Paxil, Zoloft, Lexapro. They have different side effect profiles and sometimes a little bit different. Some give you more energy than others. Some are a little bit better for helping with pain. So we choose based on that. I think I have a slide on that. Yeah, that's the slide, how to choose an antidepressant among all of these. So what has worked for you in the past, if you've had one? What's worked for a first degree blood relative? Often if you have a first degree blood relative that's it's worked for, then it'll work for you. And then what's the agent least likely to interfere with other medications and or have some of the other effects I might want, like some energy for patients with fatigue. But other than that, it's a trial and error. Although I've used psychostimulants quite a bit, and psychostimulants have a rapid effect in hours to days, not weeks. There seems to be minimal side effects with them. They can be continued indefinitely. We use these for people with ADD and ADHD who can be on them for a lifetime. You can continue to increase the dose until you don't get a more benefit or until you get a side effect. You don't seem to develop tolerance, meaning you don't seem to need more over time. It can help with opioid-induced sedation or sometimes cancer fatigue, not always. And it may also help with some pain. And these are, people respond about 70%, not 30% to these. So they're not a bad choice. I don't often go to them first unless I'm in a time-sensitive situation. If somebody's near the end of life and they have a few months to live, I'm not going to waste months trying to find an SSRI for them to work. Somebody's just been diagnosed, and we have time, then I might use a more traditional antidepressant. So what do we do by addressing depression? We decrease suffering and improve quality of life. We increase positive cancer care outcomes and improve diagnosis. Patients are actually more likely to adhere to their cancer regimens, which means that they're more likely to work. It helps with sometimes hard to treat or symptoms not responding, like pain. So we talked about how pain led to depression, but depression can make pain feel worse. And so by helping with the depression, that can help with the pain when increased pain medications are not working. And then we talked about reducing unnecessary hospital visits. And, hospitals think of this in terms of money savings, but patients don't like going to the emergency room or being admitted to the hospital either, right? And they certainly want to get out of the hospital as fast as they can. So by treating depression, we can help to minimize that. So we talked a little bit about what depression is, especially how it can be a symptom or a clinical syndrome. Easy ways to screen for it with 2 questions about are you depressed and are you getting any joy, and that we can manage it with both talk therapy and medications. So with that, I'm done. I've seen several questions come through the chat, and we can take more live as well. I will take my slides down so we can look at each other. All right. So in the chat, somebody asked, depression have no energy to be angry, right? You can see people with lack of energy, but I haven't found that they're too tired to be angry. Not everyone that's depressed is angry, but certainly patients that feel irritable or angry, I haven't seen depression modify that one way or the other. If anything, I think they feed on each other. But anxiety develop into depression much? Yes, it can. So both ways. So I as an expert, I need to tease apart, is this separate anxiety and separate depression, or has someone become depressed and now that makes them anxious because they're anxious because they don't enjoy anything or what have you, and the way I'm going to treat the anxiety is by treating the depression, or vice versa. The anxiety limits their ability to engage in life to a point where it becomes depressing, and then by treating their anxiety, often I can help the depression. Now, the antidepressants actually treat both, so it's usually the same treatment anyway, but I might use some other things for anxiety differently depending on what's before me. Eating orange, I assume that means oranges strangely helped my depression in the past. Not surprised. And I, people will say all sorts of things about what helps their depression or anxiety. And as far as I'm concerned, if there's no harm, if you're not eating enough oranges to poison yourself, that's fine with me. So any of the things that we talk about that have no risk are worth trying. And if they work, great. It's the things that come with risk, like medications and side effects, that then I get concerned about appropriately using them. Bright light, including earliest morning hours, when UV rays not producing so much vitamin D. I mean, you want bright light, so early morning hours when the sun is up is still better than nothing. It turns out also going to the beach, the ionization from the waves crashing seems to help too. But I don't know that there's been research on whether, evening light, morning light, et cetera, that I know of. But I haven't been on top of that literature as far as when you get the light, just making sure you get it. Or you can purchase bright lights that you can, I could put in front of me now while I'm talking to you, make it shine on me for a half an hour, and that helps too. But they have to be the ones that give like solar type of light, or sometimes they'll skew it towards like the blue light spectrum, and they have to be strong enough. So not any light will work. Might a temporary course of psychostimulants be helpful in supporting resolution of situational depression? So it depends on what you mean by situational depression. And I think that's a term that's fallen out of favor, in that anything can lead to depression. It can come out of nowhere. It can come out of, getting diagnosed with cancer or getting a poor prognosis. It can come because, of temporary stress. For me, the question is, do you meet criteria for a clinical depression or not? If you don't meet clinical criteria for clinical depression, I'm not typically thinking of a medication. Sometimes if you're close enough, I might, and there is evidence that what's called minor depression, not quite meeting those criteria, medicine can help. But to me, that's the line. And then choosing the right medication for you is what I would do. So it would depend on your situation, but yeah, a psychostimulant might be okay to help get you through if you meet those criteria. So I guess my point is, it doesn't matter if a situation triggered it or not. It matters what level of depression you have and what's the best way to approach it. That was the end of the questions in the chat. So I'm happy to answer more through the chat or if you want to speak up.
I had a question. There was a slide and I didn't get to copy it down in time, but I think it was about determining which antidepressant, because it said number one, what's worked in the past, number two, a blood relative, and there was a number three.
Um, uh, Number three was things that are not going to interact with the medications that you're taking, or and I didn't say this on the slide, but have a positive side benefit profile. Like some are more energizing, so if you have fatigue, I might give you one of those. Some are more sedating, so if you're not sleeping, I might give you one of those. I think we're going to give you the slides, and I think we did for anxiety. Is that right? So yeah, we can give you the slides, so you don't need to copy things down.
That would be
Thank
great,
you.
Dr. Ren. Thank you.
Did I
Thank
give you
you.
the anxiety slides for that last time or no?
I don't think so.
Okay, I'll make sure I do that today.
Thank you. I had another question come in. They're asking, what if your loved one has had very difficulty holding on in life, almost like PTSD their whole life? I'm worried this cancer will drive him over the edge. Her husband, her and her husband are losing faith in God over this, so they don't know how their son is going to take this. They're saying her son is a high functioning bipolar, but he refuses to believe that, and he feels it's more PTSD his whole life.
I'm sorry, so what was the question?
I guess I'm not too sure what the question is, but it seems like
And who has the cancer? Is it the son with bipolar or the father?
So I'm just worried that if you already have a history of, I don't know if you call it depression, when you have PTSD your whole life and it just, you're trying and struggling your whole life to get through that part, and you're holding on to life and you keep on trying to make it through, and then you get whacked with this, I'm just wondering, it's more so than just simple depression. I mean, what do you do? Where do we turn?
Yeah, well, so PTSD is an anxiety disorder that has treatments for it. And to your point, often people with PTSD, additional traumas, so a diagnosis of cancer or a poor prognosis is an additional trauma. So if the PTSD is well controlled, then hopefully the person can incorporate that into the therapy, and the medications will help. If it's not controlled, I think you're right. It's another trauma that is additive. I would absolutely look towards experts in PTSD treatment. There is something called medical PTSD that patients get from going through treatment or getting the diagnosis. And then there are trauma therapists, and I would absolutely look into getting a trauma therapist. Now, if it's bipolar and not PTSD, one, traumas just make mental illness worse, no matter what it is, depression, bipolar. But two is you want to make sure that bipolar is being addressed and controlled, which can be harder to do if somebody doesn't admit that they have or think that they have bipolar. To the extent that the treatments can overlap between PTSD and bipolar, that might be a way in. So it sounds to me like if the person's willing to get help, a thorough assessment by an expert in PTSD and trauma, and making sure that they get appropriate medication and talk therapy. And the cancer diagnosis is just like any other trauma in life, as far as from that perspective, that they will need help with that additional trauma.
Yeah, it sounds like, yeah, thank you. The PTSD and the trauma support is really what he's going to need. And the bipolar is just something we'll put in the wayside now unless our therapist picks up on such a thing. Yeah.
Yeah. Hopefully that answered the question and was helpful.
Yes, it was. Thank you.
Other thoughts, comments, questions? All right, well, I guess ran a little short today, so everybody gets some time back. But thank you all for having me. I hope this was helpful and beneficial. It was my pleasure to be here with you.
Thank you.
Thank you.
Thank you.
Everyone will get the survey emailed, and then I'll gather all those surveys and the responses, and then Dr. Irwin will also send those out to you as well.
Great, thank you so much.
Thank you.
Thank you.
Have a good afternoon, everybody.
Thank you too.
You.